How's it going, guys? Medium difficult question, pathology, step 1, internal medicine, 2CK. 51-year-old woman. Few-minute episode, lost of consciousness. She was watching TV while this occurred. No bowel or bladder incontinence. No tongue biting. 30-year history of smoking. 5-year history of type 2 diabetes. Vitals normal. Neurologic cardiac exams normal. ECG shows Q waves in V2 through V4. I'll talk about this as we move through. Which of the following most likely explanation? Choice A, Adam Stokes tack. Wrong fucking answer. Pediatric diagnosis shows up once on one of the forms. This is a seizure-like episode that is due to an arrhythmia that results in transient hypoxia to the brainstem. EEG shows no abnormalities. Choice A, wrong fucking answer. Choice B, constrictive pericarditis, wrong fucking answer. Pretty much non-existent diagnosis on USMLE. You could be aware that TB is most common cause worldwide, causes calcification of the pericardium. Could be due to history of radiation to the chest, e.g. from history of Hodgkin. Students will confuse this with cardiac tamponade. But as I said, it doesn't really matter, just for explanation's sake. Tamponade exceedingly high yield, which is going to be history of trauma to the chest, could be left ventricular free wall rupture post-MI, sometimes due to malignancy, where you get Beck triad, hypotension, JVD, muffled heart sounds, plus or minus pulsus paradoxus, and you get a negative Kussmaul sign, whereas constrictive pericarditis is a positive Kussmaul sign, which means paradoxical increase in JVP with inspiration. Normally, inspiration, decrease intrathoracic pressure, increases venous return to the right heart. You should have a mitigation of any elevation of jugular venous pulsation. Well, with the rigid pericardium and constrictive pericarditis, you have insufficient venous return, even in the setting of inspiration, results in a paradoxical increase in the JVP waveform, whereas with tamponade, the mobility of the fluid in the pericardium where you have inspiration allows somehow for sufficient venous return. Point is, wrong fucking answer. Choice C, non-ketotic hyperosmolar hyperglycemic crisis. For Bose answer choice, wrong fucking answer. So all you need to know for USMLE is that this is type 2 diabetes, whereas DKA is type 1. It's literally that simple, okay? So you get a 15-line rambling paragraph. They tell you patient has type 2 diabetes, and they'll tell you serum glucose is 700, and there's confusion, and they just want non-ketotic hyperosmolar hypoglycemia as the answer, and you would need to know DKA is wrong. Okay, that's pretty much the important point. So DKA type 1 and choice C is type 2. You're going to give fluids first without insulin as the next best step for 2CK. Okay? Wrong fucking answer. Choice D, paroxysmal atrial flutter, correct answer. So this patient has QAs in V2 through V4, which means history of myocardial infarction. And that's exceedingly high yield because, holy shit, if you've had history of MI, wouldn't you have a degree of fibrosis of the myocardium that could lead to electrical malconduction and hence increased proclivity for arrhythmia? So it's not the actual specific arrhythmia that matters here. We could have written paroxysmal atrial fibrillation, paroxysmal supraventricular tachycardia, Wolff-Parkinson-White syndrome. Doesn't fucking matter. It's the fact that we eliminate to get there in combination with history of MI via the mechanism as I just explained. So that can result in the loss of consciousness in this case. Let's just go through the final answer choice. Seizure, wrong fucking answer. I mean, not really dramatic here. I said no tongue biting. This can be sometimes a buzzy descriptor. Wrong fucking answer. You know the deal, McTeam. Make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.